colorectal, and then prostate. And then for the females, the majority, still number one is our breast, CA, from our cervix uteri, and our colorectum. So for both sexes, the number of new cases, number one is breast, followed by our lung, CA, and then third is our colorectal. And then for the number one cause of mortality last year, it is with lung, CA. So modern cancer therapy is a multidisciplinary approach. So it's not just the doctors, the different specialties, but also including our nursing staff, our rehab staff. Everyone is part of the team in handling our cancer patients. So first, let us define primary versus adjuvant therapy. So primary or definitive surgical therapy is the en bloc resection of tumors with adequate margins and regional lymph nodes. While adjuvant therapy is aim is for local and regional control with our radiation therapy and for the treatment of distant foci of subclinical disease using our different systemic therapies that we will tackle upon later. So this picture shows a summary of why our cancer cells have such an unregulated growth. So in a normal human being, a normal setting of our cellular homeostasis, any damaged cells, mutated cells are destroyed. But there are some cells that evade the body's protective mechanisms. So they evade our growth suppressors, they avoid immune destruction, they induce genomic instability and cause mutation. That's why they have an unregulated growth. So these different processes, these unregulated processes, it is in these processes that we try to make our medications. So our therapies targeting our different processes. So for example, in avoiding immune destruction, we develop immune activating molecular substances. So what are proto-oncogenes and oncogenes? So proto-oncogenes are just normal cellular genes that are present in the body. But when they are mutated or they are damaged, they can turn abnormal. So they become oncogenes. So our oncogenes can be a lot of things. They could be our growth factors like our PDGF or platelet-derived growth factors. They could be growth factor receptors like our HER2. They could be intracellular signal transduction molecules like our RAS. So before we proceed, we will tackle upon apoptosis or our programmed cell death. So when the cell suffers damage, whether externally or internally, or if the body decides that these group of cells are not useful anymore, so the body induces a ordered sequence of cellular destruction. So first, in our apoptosis, there are signals that they send to our cells where the ordered destruction begins through condensation of our nucleus, formation of our blebs, and then formation of the blebs into apoptotic bodies, which are then phagocytized. And then these raw materials are recycled to make new cells. So we have two pathways for apoptosis. We have an intrinsic or mitochondrial pathway and an extrinsic or a death receptor pathway. So for an intrinsic pathway, whenever there's a cellular damage, it could be from an external source like UV radiation, causing damage to our cells, or from our reactive oxygen species. There will be a destruction, and the mitochondria, the powerhouse of our cell, releases our cytochrome C. And the cytochrome C activates the family of or caspase 9, which in turn activates another caspase family 3, which are the effectors that causes your apoptosis. As for the extrinsic pathway, there will be a binding of your ligands to the so-called death receptors, which in turn signals caspase 8 family, and then this caspase 8 will in turn activate your caspase 3, which are your effectors that causes the apoptosis. So we also have something called autophagy, which in a way it is self-eating in layman's term. So what it does is um, broken down materials inside the cell are lined by this phagophore. They are placed inside these vesicles where digestive enzymes called lysosomes merge, and then they break down this debris, this cellular debris, and turn them into raw materials to be used for the cells. So for cancer invasion and metastasis, this picture here shows a very good picture for cancer invasion. So, example, this is your group of cells, and then this one cell here, and then this one cell here is our cancer cell. So, this is like this is your basement membrane, and then if cancer cells have not yet invaded through your basement membrane, they are called your in situ cancer. Usually, cancer cells have a difficulty going through your basement membranes because your cell have molecules called cadherins that that makes them bind together so that um, they won't be able to move freely. But when a cancer cell does pass through or invade through your basement membrane, then we can say that it is already an invasive. There is already an invasion. So your cancer cells has these integrins that allows them to interact with your extracellular matrix. And then your cancer cells also activates your matrix metalloproteins and your plasminogens that in turn breaks down your ECM and allows greater motility for your cancer cells. So when the cancer cells breaks through your basement membrane into the ECM, they have an option to go through your blood vessels through hematogenous spread, or to your lymphatics, your lymphatic spread. And then here, the process of metastasis is quite inefficient, since not all cancers that are able to enter your lymphatics or your blood vessels will survive. So they have to enter and travel to other tissues where there will also they may undergo dormancy, or they may go into a quiescent state until they are activated by a future stressful event, or they may try to multiply, but without a good source of nutrients. The rate of multiplication versus the rate of apoptosis is almost equal, so they cannot grow large. So what happens, these cancer cells, they induce your angiogenesis, or they try to make blood vessels of their own so that they can get nutrition from the blood. So here we have our tumor angiogenesis. So what happens? So this is our group of cancer cells. Now they are already in other organs. They induce a sort of hypoxic state, and this hypoxic state will induce your angiogenic factors, your vascular, your VEGF, your EGF, and then this in turn will attract and cause growth of your vessels. So as you can see in this picture, slowly vessels are being formed, and once they connect to your cancer cells, so the cancer cells have already access to your blood supply, so they can get more nutrition. So sometimes we can predict which areas the cancer cells can grow into, but usually this is due to the anatomy itself. So where the blood flows, the cancer will also grow. And also if the environment that they are in, if it is if it is favorable for the cancer cell, then the cancer cell will also grow there. So for cancer genomics, or the study of genes, um, especially those of a normal genes versus those that can cause cancer. So we have two things that we need to remember here. So our germline mutations and our somatic mutations. So germline mutations are hereditary, so they are passed from parent to child. And then as for the somatic mutations, they are acquired. So the body suffers every day a lot of damages, molecular damages, but is always being repaired. But sometimes there are damages that cannot be repaired, and that's why they can also be causes of our cancer. So hereditary cancer risk factors. If the tumor development is at a much younger age than usual, there's presence of bilateral disease, multiple primary malignancies, presentation of cancer in less affected sex, clustering of the same cancer type in relatives, or occurrence of cancer in association with other conditions. So here are some of the genes associated with hereditary cancer risk. So for example, there are mutations in your BRCA1 or BRCA2 because your hereditary breast ovarian CA. Your alterations in your APC can cause your familial adenomatous polyposis. So on. So we have different kinds of carcinogens. We have our chemical, physical, and viral carcinogens. For your chemical carcinogens, we need to remember these three things. We have our genotoxins, which are substances that initiate carcinogenesis by inducing a mutation on your cell. Then we have your co-carcinogens that by themselves they cannot cause cancer, but they enhance the potency of your genotoxin. And lastly is your tumor promoters that after exposure to your genotoxins, they enhance the following formation of tumor. So we have this International Agency for Research on Cancer. They classify carcinogen into 5 groups. So we have group 1, which are proven to be carcinogenic to humans. So this includes substances like your alcohol and your tobacco. So 2A, which are probably carcinogenic, 2B, which are possibly carcinogenic. Third is not classifiable as to its, so there's no study that it can cause cancer to humans. And the fourth is they cannot cause cancer to humans. So we have our second group, our physical carcinogens. They cause cancer by induction of inflammation and cell proliferation over a period of time, or through exposure to physical agents that cause DNA damage. So example of this are your radiation, chronic non-healing wounds, burns, and even presence of foreign body. Our third kind of carcinogen is your viral carcinogen. which are classified under your oncogenic RNA and your oncogenic DNA viruses. So your oncogenic RNA viruses, these are usually retroviruses with reverse transcriptase. During their growth in the body, they usually multiply by incorporating into the host DNA. As for the DNA viruses, they multiply by replicating inside your cell and then with the following destruction of that cell to release the viruses. But sometimes during the process of the replication, the cells won't splice, so their DNA makeup are incorporated into that cell. And when that cell divides, so so when that cell divides, there will be an alteration already in the genetic makeup. So as for cancer risk assessment, it is important um, to determine cancer screening recommendations because they may alter how aggressively an indeterminate finding will be pursued for diagnosis. So your risk assessment will always start by taking a complete history, including your environmental exposures to potential carcinogens and also your family history. So we have risk assessment models, an example of which is your Gale model for breast cancer. So for cancer screening, early detection is always the key to success in cancer therapy. So in different areas, there's different prevalence of your cancer. So there's always development of the screening guidelines always depends on which areas they are from. So key factors that influence the screening guideline is number one, how prevalent the cancer is in the population. And then number two, what risk is associated with the screening measure, how invasive it is to do, or how expensive it is to perform. And then whether early diagnosis actually affects outcome. So for cancer diagnosis, definitive diagnosis of solid tumors is obtained by performing a biopsy specimen of the lesion. So we have our needle biopsies, our fine needle and core needle biopsies, and our open biopsies, which are our incisional and excisional biopsy. So for our fine needle biopsy, it is usually easy and safe to perform, but it does not give information on our tissue structure compared to our core needle biopsy. But both our fine needle and core needle biopsy can have a sampling error. We could be getting in areas that is not representative of the tumor. Sometimes we can take a benign sample and it turns out that the tumor is actually malignant. So if the needle biopsies are does not correlate clinically, it should be either repeated or followed by an open biopsy. So in open biopsies, more tissue samples are taken. As for those very large tumor, we usually do an incisional biopsy or we just take a part of the tumor. If we do an excisional biopsy, we always do it with a curative intent. So there should be an adequate tissue surrounding the tumor to ensure negative surgical margins. So next is our cancer staging system used to describe the anatomic extent of a malignant process. So it is essential so that we can design the appropriate treatment regimen for an individual patient. So standardization in our cancer staging allows for comparison of results in different areas. So usually we use the TNM staging system, our tumor node and metastasis. So we deal with the size of the primary tumor, the presence or absence, and extent of nodal metastasis, and the extent of distant metastasis. So our cancer staging assists in selection of therapy, estimation of prognosis, evaluation of treatments, and also important in research as to the exchange of information among treatment centers. So next is our tumor markers. So they are substances that can be detected in higher than normal amounts in serum or any other body fluid with certain types of cancer. So they can be classified into two, your prognostic markers and your predictive markers. So your prognostic markers predict disease-free survival and overall survival, while your predictive markers predict response to certain therapies. So it's all important to remember that tumor markers are not specific for certain types of cancer, and then they can be elevated with more than one type of tumor. So when a tumor marker is used to monitor recurrence, it is important to be certain that the level of the tumor marker was elevated before our primary therapy. So for cancer therapy surgical approaches, for our primary tumors, the goal of surgical therapy is always to achieve oncologic cure. So operability of a tumor is best determined before surgery with appropriate imaging studies that can define the extent of local regional disease. So to achieve widely negative margins with no evidence of macroscopic or microscopic tumor at the surgical margins. But there are instances that uh, we do surgical resection for palliative reasons, so such as to improve the quality of life by alleviating pain, infection, or bleeding. So most oncologic operations are designed to remove the primary tumor in the draining lymphatics. So there's generally accepted that a formal lymphadenectomy is likely to minimize the risk of regional recurrence of most cancers. But current surgical approaches lean on conservative therapy. So that's why we develop lymphatic mapping and sentinel lymph node biopsy to identify and remove the lymph node most likely to contain metastasis in the least invasive method. So why we do this is that in order spare um, to spare lymphadenectomy in patients with negative lymph nodes. So an example in this picture, um, in lymphatic mapping, there's an injection of a dye around the tumor, and then once the tumor um, takes in the dye, we can visualize where the tumor primarily drains. So the first node that the tumor drains is called your sentinel lymph node. So So surgical approach for distant metastasis depends on the number and sites of metastasis, the cancer type, the rate of tumor growth, the previous treatments delivered and the responses to these treatments, and of course the patient's age, physical condition, and desire. So next is our chemotherapy. So the goal is also to decrease the tumor burden and prolong survival. So we have our preoperative adjuvant, or otherwise known as your neoadjuvant chemotherapy. So it is administered to a patient who is high risk for distant recurrence but has no evidence yet of distant disease. It is to eradicate micrometastatic disease with the intent of decreasing relapse rates and improving survival. So advantages include preoperative regression of tumor. So they make the tumor smaller so that it can be easier to resect. Treatment of micrometastasis without delay of post-operative recovery, and assess a cancer's response to chemotherapy. But there's also a caution in using your neoadjuvant chemotherapy, especially for resistant tumors like your sarcomas, as doing neoadjuvant treatment causes a delay in surgery. So chemotherapy principles follows your first order kinetics. So it's more on per treatment, the chemotherapeutic drug will kill a constant percentage of your cancer cells. So we have two kinds of agents, your cell cycle phase non-specific agents versus your cell cycle specific agents. So for your non-specific agents, they follow a linear dose response curve. So they kill more the more you add these agents to your treatment. So examples of which are your alkylating agents and your anti-tumor antibiotics. They act on all phases of your cell cycle. As for the cell cycle specific agents, they reach a plateau in terms of killing. So when they reach that level, any more agent or any more of the drug you add, they will not increase the cell killing. So we have your anti-metabolites, which are usually your folate, purine, and pyrimidine antagonists. They target your S phase. And we have your plant alkaloids, your vinca alkaloids, which binds to your tubulin at S phase, preventing mitosis in your M phase. We have your taxanes, which causes excess stability of your macrotubules, thus also disrupting your M phase. And your etoposide, which inhibits your topoisomerase 2, so it disrupts your DNA synthesis and disrupts your G1 phase. So we have a principle of combination chemotherapy so that we can achieve a maximum cell kill within the range of toxicity for each drug. So we can also achieve a broader range of coverage, especially for resistant cell lines in a heterogeneous population, and also delays the emergence of drug-resistant cell lines. So for drug toxicity in chemotherapy, it usually the cancer cells are more susceptible to your chemotherapeutic drugs because they are rapidly dividing compared to your normal cells. But in the body, there are also cell lines that are rapidly dividing, such as in your hair, in your GI tract. So that's why toxicity causes alopecia, ulceration in your GI tract. The next, radiation therapy. Radiation results in DNA damage manifested by single or double strand breaks in the sugar phosphate backbone of your DNA molecule. So radiation damage is manifested primarily by the loss of cellular reproductive integrity. So when the cancer cells get hit by your radiation, it does not die instantly. But when it starts to divide, there is an arrest of your reproductive cell and the production of your cell. That's why it is there that we can show the effect of your radiation. So radiation sensitive phases are your G2 and your M phase, while your G1 or your late S phases are less sensitive because it is in this G1 and late S phases where the cells are not dividing as much as your G2 and M phases. So in the planning of our radiation therapy, it's important to define the target to be irradiated as well as those limiting organs in the vicinity of the tumor. So we can add immobilization devices or markings or tattoos on the patient's skin to ensure that daily treatments are given in the same way. So in this picture here, we have an example of our external beam therapy. As you can show, this is a focused beam of radiation hitting this in this picture in this tumor inside the breast. Then our aim for this is to prevent it from hitting other organs that have a lesser risk of acquiring the tumor. So adjuvant radiation therapy, we have our preoperative and our postoperative radiation therapy. So the advantages of our preoperative includes to minimize seeding of the tumor during surgery. So it allows for smaller treatment field since the operative bed has not been contaminated with tumor cells. So there is tumor size reduction. But the disadvantage is we have postoperative wound healing problems. So our postoperative radiation therapy, usually done 3 to 4 weeks after surgery to allow healing. Advantages include surgical specimen evaluation, allows for better patient selection. And then because we already have the tumor specimen, we can better modify our radiation therapy because we already know our margin status. But the disadvantage for post-operative radiation therapy is that larger normal tissue irradiation is needed due to surgical contamination of the tissue planes. So we have another type of radiation therapy called your brachytherapy, in which the radiation source is in contact with the tissue being irradiated. So it is administered temporarily or permanently using implants. So for this picture, so this is a sample of a prostate cancer where this radioactive needles or seeds are inserted. So this minimize the uh, this minimize the systemic effects of irradiation as it is more localized in action. So we have our other therapies. First is our hormonal therapy, which is a highly tumor-specific form of therapy in sensitive tissues. So we have hormones or hormone-like agents that can be administered to inhibit tumor
Since
growth.
pagkabata namin, ako nagtugod sa basag Bible pag fourth year pa.
This
Outer year.
defense or your
First
aromatase.
yung ablipas Bible sa kanba. First pag ito ako, ano, pag first week class na to, CL kami ng first class eh. First week ako ablis Bible to ba?
Next is your targeted therapy, which exploit the molecular differences between normal cells and cancer cells. So, an ideal molecular target would be exclusively expressed in the cancer cells. And then this would be the driving force of the proliferation of your cancer cells and be critical to their survival. So, the targeted therapy is usually targeting these specific molecules that are present outside or inside your cancer cells, such as, for example, our trastuzumab that targets our HER2 receptor. The next is our immunotherapy, which in a way induce or potentiate your inherent anti-tumor immunity of the body that can destroy your cancer cells. So this activates the immune system, and the immune system will recognize your tumor-associated antigens um, present in your human cancers and destroy them. So an example is your administration of Basil, Camet, and Guerin, or your BCG, especially in the treatment of your bladder CA. So lastly is your gene therapy. Now this is a new concept in which, um, like how a virus infects the cell, your gene therapy uses a vector that delivers your treatment inside the cancer cells. So this is very specific, but so far it is still undergoing studies. So I think that's my last slide. Thank you for listening.